Okay, today we'll discuss about history taking and examination in movement disorder. Okay, any movement disorder, whenever taking the history or doing examination, these protocols should be followed. First, you should ask age, onset, what all the sites are affected, whether the movements are continuous or episodic, whether these movements are comes in regular interval, what about the sleep, whether there is any aggravating or relieving factors, whether there is any diurnal variation, whether the movements are suppressible voluntarily or not, or any inner tension to move the movements. You should inquire because every point carries diagnostic hint towards the movement disorders. Okay, am I audible?
Yes, sir.
Okay, next slide. So first come to the age of onset because various movement disorders will occur in various age group. Okay, say for an example, Parkinsonism, usually it occurs after the 45 years of the age. If it occurs before 45 years, again it can be classified as young onset Parkinsonism and juvenile onset Parkinsonism. Young onset Parkinson's would be age between 21 to 45 years, and juvenile onset Parkinsonism would be less than 21 years. Okay, in young onset Parkinsonism disease, will have levodopa related complications like dyskinesia compared to the idiopathic late onset Parkinson's disease. Just to remember the rule of thumb 40, 50, 60, 70. Most of progressive supranuclear palsies will occur age more than 40 years, never before 40 years. And idiopathic Parkinson's disease will start occur after 40, like 40, more than 45 years, but juvenile varieties are also common. Mean age would be around 55 years, and the multiple system atrophy mean age would be around 60 years, and corticobasal degeneration syndrome will occur mean age of more than 70 years. Other exception can also be possible. Just you remember these rule of thumb. And other movement disorders like myoclonus, most oftenly we see in pediatric age group in the infantile stage. Chorioathetosis dystonia may be secondary to basal ganglia insult, may be seen at the end of first year. Tic disorders, generalized dystonia, dopa responsive dystonias, most commonly seen in second decade. Choreochromatic origin would be between second to third decade. Focal and multifocal segmental dystonias commonly occurred in third to fourth decade. And Huntington's chorea will occur more than fourth decade. And essential tremors would be around between 50 to 60 years of age. And hemibalismus, hemichorea would be occur between would occur more than 60 years of age. So just common age of presentation. This is not the rule of dictum. Just you remember common age of presentation of various movement disorders. Exception can also be possible. Then ask for the how is the onset of symptom, whether it is acute or subacute or chronic. Some of the movement disorders like hemibalismus, chorea, myoclonus, epilepsy partialis continua will occur acutely, very acutely. In your medical emergencies, you might have seen hemibalism, chorea secondary to non-ketotic hyperglycemia induced status. And in acute renal failure and chronic liver diseases, liver failure may also causes myoclonus. Epilepsy partialis continua may be secondary to secondary brain injuries that are involving the cerebral cortex, predominantly frontal lobes. And let us come to subacute onset. Most of the tic disorders and chorea will come under the subacute onset. And chronic onset, chronic duration of the illness in seen in most commonly Parkinson's disease, dystonia, other varieties of chorea, and tremor syndrome. Just you ask the answer. So depending on the answer, you can make it the a particular movement disorder that occurred in the patient. Let us come to the site of involvement. Focal dystonias most commonly affect the scalp and forehead muscles, and eyelids, that is blepharospasm, most commonly seen in adults, and tics that are involving the eyelids are most commonly seen in young patients. Perioral regions, that is, as all of you know, that is rabbit syndrome, that more predominantly involves the perioral region. This is also called tardive dyskinesia, secondary to the long-standing usage of antipsychotic that leads to the dopamine receptor hypersensitivity. And chin tremors most commonly seen in Parkinsonism, and tongue most commonly involved in the lingual dystonia, as you know, Wilson's disease that most oftenly affect the oromandibular dystonia. So tongue also affected. Laryngeal and pharyngeal dystonias also be defined. Laryngeal dystonia may be The terminology would be spasmodic dysphonia and pharyngeal dystonia. Neck muscles, you might have seen cervical dystonia commonly affect the neck muscle. This is sternocleidomastoid muscles would be most commonly affected. Hands, that is hand writer's dystonia, writer's cramp, hand tremors. Trunks, most commonly seen in again drug-induced tardive dystonia syndrome. Legs, in leg dystonia, restless leg syndrome, and dopa responsive dystonia will commonly seen in the legs. Let us come to the movement disorders, whether these movement disorders are continuous or paroxysmal. Most of the movement disorders are continuous and spontaneous, as all of you see: chorea, athetosis, tremors, dystonia. And some of the disorders are very task specific, like writer's cramp during the writing, and orthostatic tremors whenever patient stand in the erect posture. And sometimes whenever musician cramps, also one more terminology is there, when a person using the tram or any violin, during that time only that dystonic movement will occur. These are called task specific movement disorder, most commonly seen in dystonia. And some of the movement disorders are very paroxysmal, like tics, stereotypic movements are paroxysmal kinestonic and non-kinestonic dyskinesias. Okay, just you remember the examples for paroxysmal and continuous. In paroxysmal, motor tics, paroxysmal dyskinesias, paroxysmal non-kinestonic dyskinesias, stereotypy and akathisia will come in a paroxysmal events. Okay, other movement disorder except above mentioned will come in the continuous movement disorder, that is spontaneous and continuous movement disorders. You ask whether the movements are regular or irregular. It is very difficult to ask in a history. Depending on examination findings, we can make it. Still, you can. Some patients may tell. Okay, the movements like tremors, myoclonus, particularly palatal myoclonus, epilepsia partialis continua, that is focal motor epilepsy, and stereotypy. These movements are very regular, and rest other all the movement disorders are irregular. Okay, just you remember the name and see the patient. Most commonly we diagnose these movements as a regular or irregular movement depending on examination findings. Okay, and just you need to ask character of movement disorder. Say for an example, myoclonus, chorea, tics will have brief jerky movements, and twisting movements will be seen in the dystonia. Rhythmic alternating to and pro movements will be seen in the tremors, and wild flinging violent movements will be seen in the balismus, and repetitive stereotypic movements are commonly seen in tics, stereotype, and akathisias. Then whether there is any exacerbating or diminishing factors in the movement disorder. Anxiety, stress will increase all kind of movement disorders. Example, tremors, chorea, dystonia. And some of the movement disorders will be diminished whenever whenever you are doing video or whenever you are observing the patients. These movement disorders will decrease. Like say for example, tics, whenever trying to do the video recording, that time tics will decreases. Alcohol intake sometimes decreases the essential tremors, essential myoclonus, and myoclonic dystonia. And strong light TV watching will increases the blepharospasm. And some of the focal dystonias will have sensory tricks. By doing the sensory tricks, by like say for example, by putting the hand on the chin or by putting the hand on the posterior aspect of the scalp will decreases the movement. Those are called sensory tricks. These things also be asked in the history. Okay, let us come to the diurnal variation. Some of the movement disorders like dopa responsive dystonias and Parkinson's disease will have early morning early morning benefit. Because of good dopa reserve, patient will have less symptoms in the morning time, and tardive dyskinesia syndromes will have worse symptoms in the afternoon. Okay, so because dopamine reserves, as the day progresses, dopamine reserve will decreases. So dopamine deficiency syndrome, say for example in Parkinson's disease and dopa responsive dystonia, they will have good they will not have any Parkinson's related symptoms in the early morning compared to the evening. So you need to ask diurnal variation, particularly in all Parkinsonism patients. Let us come to the sleep. Okay, some of the movement disorders will appear in the sleep. Some of the movement disorders will disappear in the sleep. some of the movement disorder will persist in the sleep. So depending on asking the sleep history, particularly in the personal history, you can ask the what happens to the movement during the sleep. Like say for an example, hypnagogic dyskinesis, periodic movement disorders in the sleep, and REM, sleep behavioral disorders, will start occur in the sleep and disappear whenever the patient awakened. And some of the movement disorders do persist throughout the night. Example, focal epilepsy, hemibalism, palatal myoclonus, spinal myoclonus, neuromyotonia, and severe tics. So rest all the movement disorders will disappear during the sleep. So this is very important history. So whenever you are taking the history of movement disorders, kindly ask sleep whether these movements persist in the sleep or absent in the sleep. So this will help you to differentiate the various movement disorders. So you need to ask whether the movements are voluntarily suppressible or not. So whether it is possible to suppress the movement, whether inner tension will develop or not. Okay. So most of the movement disorders are involuntary, except these tics and stereotypy and akathisia. Tics patient will have some amount of voluntary suppressibility, but whenever patient tries to suppress the movement voluntarily, that will leads to increase in the inner tension. Then patient will the patient will start doing the movements. Okay. And stereotypy and akathisia movement can be suppressible for a time. Okay. So these are the differential diagnosis can be made depending on asking the history of suppressibility and inner tension. So just along with the semiology, we need to ask the associated complaints like autonomic function, cognitive, cerebellar, neuropathy related complaints, psychiatric problems, hallucinations, all those things to be asked. Autonomic complaints are very important. Autonomic complaints in the form of urinary symptom, urge incontinence, or hesitancy, or urgency, frequency, incomplete evacuating, whether patient having voiding symptoms. You need to ask all these urinary complaints because most of these multiple system atrophy patients will have urinary complaints. And meanwhile, whenever you are taking the patient of movement disorder or dementia, you need to ask erectile dysfunction because this is the earliest autonomic dysfunction that used to occur in the multiple system atrophy patient, male patient. You need to ask erectile dysfunction in all movement disorders and cognitive dementia patients. And cold calming extremities and coat hanger headache. This is the headache most commonly seen in the nape of the neck and shoulder, secondary to the orthostatic hypotension. And other symptoms like blackout vision on the standing in a partial hypotension, recurrent syncope, fainting episodes, hypohidrosis, and hyperhidrosis. These are all the symptoms you need to ask uh, to rule out the autonomic dysfunction in the neurological disorders. Second one is slowness. So slowness can be asked in the history also, and you can demonstrate in the examination also by asking the day-to-day activities of living of the patient. Say, for example, shaving, brushing the teeth, and putting the makeup, and arm swing whenever walking, and handwriting, gait, shoulder movements. All those things can be asked in the history. Whether patient having any patient taking much time as compared to earlier to do the routine activities of daily living. So this is the main feature of Parkinsonism. So bradykinesia slowness is a key and major diagnostic criteria for Parkinsonism. So you need to ask bradykinesia in the history always whenever you're taking the movement disorder patient. Next, hallucinations. Most commonly, visual hallucination can be seen in Lewy body dementias. It may be formed or ill-formed. Form means patient can able to describe all the kind of visual hallucination like objects or persons. Ill-formed patient cannot able to describe properly. There was bizarre type of visual hallucinations will be there. Most commonly seen in the Lewy body dementia because degenerative diseases most commonly start with the occipital lobe. So patient will have definitely visual hallucinations. Sometimes patient those who are on levodopa or amantadine or trihexyphenidaine as a purpose of treatment in idiopathic Parkinson's disease, that time also you may patient may complain of hallucination. So in that, drug history is very important. So you need to withdraw the drugs, those causing the visual hallucinations. So visual hallucination will give clue to the diagnosis of the disease and complications that are occurred secondary to drugs in the Parkinson's disease. Okay. Again, history of fall is very important. As all of you know, postural stability is the very important aspect in a human being to maintain the erect posture whenever walking or doing activities. This postural stability is managed by pediculopontine nucleus, which is located. So whenever the degenerative diseases like synucleinopathies or Parkinson's disease will causes the degenerative changes in the pontopedicular nucleus, pontine peduncular nucleus. So the degenerative diseases which affects the postural stability centers that will leads to the postural instability. So the history can be patient will give fall backwards whenever getting up from the chair. So whenever walking, patient used to fall back. So these are the histories will be given by the patient. So whenever you are asking the history, you need to ask other complaints like visual, vestibular, cerebellar, proprioceptive function, orthopedic condition, because all will also causes the fall in the elderly. So after ruling out all these causes, you can uh, attribute it to postural instability by asking the detailed history and examination for the postural instability. This postural instability most commonly seen in progressive supranuclear palsy in the early part of the illness only. So if a patient started having Parkinson's symptom and history of fall within 1 year of onset of Parkinson's disease, so you can cannot tell that this is not a typical Parkinson's disease. In a typical Parkinson's disease, that is idiopathic Parkinson's disease, patient will not have early falls. A patient having Parkinson's symptom along with the early falls, you need to suspect atypical Parkinson's syndromes like progressive supranuclear palsy. And in multiple system atrophy, also you can see recurrent fall due to the orthostatic hypotension. And in vascular Parkinsonism, due to the gait disturbances, patient will have recurrent fall. So Parkinson's patient with early fall, you need to rule out progressive supranuclear palsy, multiple system atrophy, and vascular Parkinsonism. So whenever you are taking the history of fall, you need to ask whether patient is falling backward or forward, whether patient had fall secondary to provoked causes or unprovoked causes, or patient is having any gaze difficulty. So if a patient is having down gaze palsy, especially in progressive supranuclear palsy, that time also patient will have fall. Okay, so down gaze palsy also you need to ask. So down gaze palsy can be asked mainly. Down gaze will be needed whenever to read the newspaper, to have the food. So patient used to turn the head to see the object, or patient used to turn the head completely to take the food. So these are the few history will be given by the patient. So down gaze palsy should be asked as a part of um, diagnosis of progressive supranuclear palsy secondary to postural instability. Okay. So cognitive dysfunction and behavioral issues to be asked in the history part also, because these cognitive decline and behavioral changes will seen in the frontotemporal dementias, because frontotemporal dementia again it will be associated with the Parkinson's disease, amyotrophic lateral sclerosis. So patient may present as Parkinsonism. So after examination and history taking, patient might have these frontal temporal lobar dysfunctions. And other diseases like Lewy body dementia, Parkinson's disease, dementia complex will also have cognitive decline, and progressive supranuclear palsy will also have patient will also have frontal lobe dysfunction, and multiple system atrophy patient will not have cognitive involvement, and if they are having also very minimal. Okay, if severe cognitive dysfunction is there, don't label it as multiple system atrophy. So you need to think of PSP, Lewy body dementia, and frontotemporal dementias. So other findings you can ask any vocalization tics. It is most commonly seen in Huntington's disease and neuroacanthocytosis. And self-mutilation behavior can be seen in Leishman syndrome, neuroacanthocytosis, and Tourette syndrome. Leishman syndrome most commonly associated with Parkinsonism-like symptoms, okay, because it do affect basal ganglia circuitry. And sensory tricks, as I told earlier. So sensory tricks will also help you to diagnose the dystonia. Say, for an example, patient used to touch the skin, cheek, and back up the head to abort the movement. So sensory tics should be asked in the history. And pathological laughter, that is pseudobulbar effect, can be seen in vascular Parkinsonism, frontotemporal dementias, and PSP. And history of muscle wasting, weakness, fasciculation can also be seen in Parkinsonism, dementia, ALS complex of Gaunt. And muscle atrophy can also be seen in spinocerebellar ataxia 3, because all these degenerative diseases most commonly associated with movement disorders. It may be hypokinetic or may be hyperkinetic. So patient may come to your OPD only with the complaints of movement disorder. So you need to all this history, like pseudobulbar effect, muscle wasting, fasciculations. Okay, all those things to be asked to differentiate from various degenerative diseases that are causing the movement disorders. Let us come to the peripheral neuropathy. Some of the movement disorders will be associated with the neuropathy, like neuropathy symptoms like burning, tingling sensation, numbness, ataxias. Okay, all those things will be seen in these neuroacanthocytosis. Neuroacanthocytosis predominantly will cause sensory axonal motor neuropathies, often may also cause sensory ataxia also. So these complaints to be asked, because it will give indirect clue to the diagnosis of neuroacanthocytosis. Okay, some of the neurodegenerative conditions like Parkinson's disease, multiple system atrophy, PSP, in the later stage, patient will have neuropathic features also. Okay, the predominant neuropathic features, uh, chorea in a patient, you can suspect neuroacanthocytosis. So history is very important. So pyramidal tract. So pyramidal tract involvement, most commonly we see in multiple systemic atrophy, progressive supranuclear palsy, and vascular Parkinsonism. It is absent in idiopathic Parkinson's disease, dystonia, essential tremors, and primary tic disorder. In some of the secondary dystonias, due to the involvement of pyramidal tract, patient will have spinal tract related complaints also. So this is also called pallidopyramidal syndromes. These are secondary dystonia along with the pyramidal tract involvement. This is called pallidopyramidal syndrome. Most commonly is seen in iron accumulation syndrome in the brain. It is neurodegenerative diseases of the brain with iron accumulation, NBIA spectrum disorders. In this condition, we can see both pyramidal and extrapyramidal tract involvement. So you need to ask for the complaints like spasticity, or by the doing the examination of tone, by seeing the clonus also, you can make the diagnosis of Parkinson plus syndrome. Okay, if patient is having corticospinal tract lesion, by history or examination, don't label it as idiopathic Parkinson's disease. So you need to see for Parkinson's plus syndrome. Other history like visual neglect, sensory neglect, useless hand. That is called alien limb phenomena. This is involuntary hand movements. Patient cannot able to control these movements. These are called alien limb phenomena. Sometimes one hand will disturb the function of other hand. That is called intermanual conflict. These are the varieties of alien limbs. Alien limbs history, sensory neglect, along with the movement disorders, you need to think of corticobasal degeneration syndrome. And some of the persistent posturing or twisting movements can be seen in focal dystonia or facial dystonia in the PSP, and blepharospasm also will involve both the orbicularis, oculi muscles. And abnormal posturing after taking the dopaminergic drugs, most commonly seen in multiple system atrophy. And dystonia, most commonly we see in the Wilson's disease and the rapid onset dystonia Parkinsonism syndrome. Some of the corticobasal degeneration syndrome patient will also have limb dystonia. The two asymmetrical focal dystonia can be seen in corticobasal degeneration syndrome patients also. And as for the other associated movement disorders like myoclonus can be seen in corticobasal degeneration syndrome, Alzheimer's disease, CZDs, and autoimmune encephalitis. Dysphagia dysarthrias can be seen in MSA and PSP. Pseudobulbar effects can be seen in PSP and vascular Parkinsonism. And two abnormal posture, that is camptocormia and PISA syndrome. Camptocormia is nothing but severe anterior flexion of the spine. Can be seen in idiopathic Parkinson's disease in the later part of the disease. And PISA syndrome is just lateral flexion of the spine. This is classically seen in multiple system atrophy, Parkinson's disease also. Okay. You can ask the history, or by doing examination also, you can make the abnormal posture. Then you need to ask the psychiatric, neuropsychiatric manifestations like frontal disinhibition, apathy, low mood, disinhibition complaint, and working memory deficit. All those things history should be asked, because this Wilson's disease and juvenile Parkinson's disease, Huntington disease, Lewy body dementia patient will have severe psychiatric manifestations. So by asking this history, you can make the diagnosis of these degenerative disorders. And sleep abnormal behavioral, this is REM behavioral disorders. As I told in the earlier classes, most commonly seen in idiopathic Parkinson's disease, MSA, and DLBD. All these are come under the synucleinopathy group of degenerative disorders. Next, you need to ask the cerebellar complaints in the form of incoordination, tremors, scanning speech. All those things can and gait ataxia should be asked in the movement disorder case, because multiple system atrophy, Wilson, and spinocerebellar ataxia will have these kind of presentation. Very important history, drug history. Any movement disorder in your OPD or emergency, you need to ask for the detailed drug history, whether it may be fast or remote. You need to ask the history of the drugs, brand, and dosage of the drug, duration of the drug, how many duration, like how many years or how many months of these drugs patient has taken prior. So drug history is very important, because drug history that can cause hypokinetic movement disorders or hyperkinetic movement disorders. So for an example, if a patient you diagnosed as Parkinson's disease, you started giving levodopa. Usually typical Parkinson's disease, like idiopathic Parkinson's disease, will have good response to the dopaminergic drug. But atypical Parkinson's disease like PSP, MSA, these are all come under the atypical Parkinson's spectrum of diseases. In this, patient will not have good benefit to the dopaminergic drug. And sometimes these levodopa long-standing usage may causes dyskinesias. Okay, dopamine-induced dyskinesias. And sometimes in multiple system atrophy and young onset Parkinsonism, patients will have severe dopamine-induced dyskinetic movement. Dyskinesias are nothing but a mixture of multiple movement. Patient will have chorea, dystonia, tremors. All those multiple mixture of movements will be there. Commonly we seen in dopamine-induced commonly we seen as an adverse effect of levodopa. And some of the antipsychotic drug, predominantly first generation typical antipsychotic drugs, will cause Parkinsonism and may leads to freezing, fascination. Most commonly this is symmetrical, but can be asymmetrical also. So antipsychotic drug history also very important whenever patient comes with the acute or subacute onset Parkinsonism complaint. And tardive dyskinesias, these are nothing but after taking long-standing antipsychotic, leading to the dopamine receptor hypersensitization, that will leads to the abnormal movement. Most commonly, it will affect the perioral muscles. That is also called rabbit syndrome. In rabbit syndrome, predominant perioral movements will be there. Tongue will be spared. These patients will be beneficial with these patients will be treated with the anticholinergic rather than dopamine. If you use dopamine in these kind of patient, again it will lead to the exacerbation of the dyskinesias. Okay, so you need to checklist all the drugs whatever taken prior to the onset of movement disorders. So some of the drugs will causes the chorea, like anti-epileptics like phenytoin, carbamazepine, valproate, anti-Parkinson's drug like dopamine, dopamine agonist, hormone spectrum, that is estrogen, lithium, baclofen, flunarizine will causes the chorea. Even flunarizine can also causes Parkinson's also. So whenever you are giving the flunarizine, other calcium channel blockers like synarizine, you need to be very careful, especially in the elderly age group, because it will causes Parkinson's. Some of the drugs like lithium, SSRIs, neuroleptic, like antipsychotic drugs, sodium valproate, beta agonist, commonly you use for bronchodilation purpose, thyroxine, aminophylline will causes the tremors. So whenever taking the movement disorder, so you always rule out culprit drug. Okay. So some of the drugs other than antipsychotics also causes movement disorders, like metoclopramide and levosulfide, most commonly used for gastrokinetic purpose. So whenever you are giving the metoclopramide and levosulfide, in a extremely age group like pediatric and elderly patient, you should be careful because one single dose will causes acute dystonic reactions or Parkinsonism. So whenever you are giving in the extreme age group of patients, be careful. Okay, better avoid these gastrokinetic drugs. And sometimes phenytoin, like phenytoin valproate, do also causes Parkinson's, tremor syndrome, and dystonias also. And anti-Parkinson's disease drugs like levodopa and MD.DM will causes dyskinesias, and others like lithium SSRIs will causes tremors. And amiodarone most commonly you use in the arrhythmia patient, it do causes tremor syndromes. Okay, so whenever you are taking the history of movement disorders, kindly checklist all the drugs dose. Okay, before working upon the other causes of movement disorders. Drug history is very essential. So come to the personal and past history. History of stroke, encephalitis, trauma, these to be asked. Okay. In a patient with the movement disorders associated with the past history of stroke and stepwise progression, you need to rule out vascular Parkinsonism or vascular progressive supranuclear palsy. And some of the diseases like young onset Parkinsonism, dopa responsive dystonias will have sleep benefit. And in a corticobasal degeneration patient will have excessive daytime sleepiness, because most of these patients will have REM sleep behavioral disorders. So night sleep will be affected. So as a part of compensatory part, patient will have excessive daytime sleepiness. Alcohol will have benefit effect like in essential tremor, essential myoclonus, and adverse effect you might be knowing, it will causes cognitive dysfunction, tremors, okay, other neurodegenerative disorders. And smoking thought to be protective in idiopathic Parkinson's disease. This is only a statistical truth. It cannot be employed in the therapy. Okay, and pesticide exposure, especially in the farmers, uh, this is also one of the risk factors for Parkinson's disease. So you need to ask the pesticide exposure also in a Parkinson patient. So history of exposure to toxin like MPTP, carbon monoxide, manganese, mercury, carbon disulfide, cyanide will also causes Parkinson's disease. So whenever you are taking the history of Parkinson's disease, so you need to rule out drug-induced Parkinson's. Okay. Secondary causes like trauma, encephalitis, SSP, CZD will also causes Parkinson's like symptoms. So you need to ask the detailed past history of any previous illness. MPTP, as all of you know, this is 1-methyl 4-phenyl tetrahydropyridine. This is the organic compound. It will causes permanent Parkinsonism. Okay. Nowadays, these toxin exposures are very rare. Okay, this is thought to be neurotoxin that used to damage the basal ganglia circuitry. Let us come to the family history. Some of the movement disorders, inheritance, like will have all the kind of inheritance, like autosomal dominant and recessive inheritance, most commonly seen in juvenile Parkinson's, juvenile Huntington disease, FTD, drug dopa responsive dystonia, spinocerebellar ataxia, and neuroperitonopathies will have autosomal dominant inheritance. And some of the X-linked dystonias, Lubbock's disease, X-linked dystonia, this is, as name indicates, X-linked inheritance will be there. And most commonly, Wilson's disease, as all of you know, this is autosomal recessive inheritance. So you take the history, do complete pedigree chart, and make the inheritance pattern. So depending on the inheritance pattern, you can make the genetic disorders diagnosis. Any doubt in the history part?
No, sir.
Okay, we'll go to examination. After taking complete history, general examination also very essential to make the confirmed diagnosis. Before systemic examination, we'll see the general physical examination. As a general physician or a medicine PG, you need to know what all the things to be seen in the GPE. Okay. Blood pressure, very important. In the BP, if a patient is having persistent hypertension, recording in a vascular in the setting of Parkinsonism. You should keep the differential diagnosis for vascular Parkinsonism, because long-standing hypertension, diabetes, that will leads to the vascular Parkinsonism. If a patient is having orthostatic hypotension, that is fall in the systolic blood pressure less than more than 20 mm of Hg, and diastolic more than 10 mm of Hg on standing within 3 minutes of standing. Okay, so orthostatic hypotension, if a patient is having, means you need to rule out multiple. You need to see for the blink rate. Normal blink rate will be 12 to 20 per minute. It is decreased in all Parkinsonism patient, markedly reduced in progressive supranuclear palsy. And you need to see for other autonomic dysfunction features like cold extremities, edema, and other. First and foremost, that is KF ring. So in any movement disorders, patient of less than 50 years, you need to rule out Wilson always. So any patient less than 50 years, maybe hypo or hyperkinetic disorders, you need to rule out Wilson always, because it is treatable condition. If you diagnose earlier part, if you diagnose earlier, you can make the patient completely symptom free. So KF ring is very important. So sometimes you can see by your eyes only. So most oftenly we have to see under the slit lamp. Okay? And you need to see the facial expression of the patient. If the facial expressions are too less, that is hypomimic space, faces can be seen in idiopathic Parkinson's disease. Retrocolis, that is colis means neck, retro means backward, that is backward movement of the neck, that is extension of the neck, that is seen in the progressive supranuclear palsy. And a scary look, that is astonished look, seen in PSP again. Rhizus sardonicus, that is dystonic faces, can be seen in the Wilson's disease. This is the one left side, that is a figure showing Rhizus sign, that is lateral flexion of the trunk. This is seen in MSA, and below mentioned is dystonic facial expression. It is seen in Wilsonian Wilson syndrome. That is also called Wilsonian dystonic smile. This is striatal hands. Striatal hand is nothing but extension at metacarpophalangeal joint and flexion at intraphalangeal joints. It can be affected in lower limb also, classically seen in the end stage Parkinson's disease. And right side one is again Pisa syndrome, that is scoliosis that is associated with the Parkinson's disease. And you need to see rabbit syndrome. So you need to examine the peripheral cavity, chin, face, hands, joints also in a case of movement disorder. There is emotionless faces or mask-like faces seen in Parkinson's disease. Axial rigidity with restricted vertical gaze can be seen in progressive supranuclear palsy. Overactivity of the frontalis, this is also called omega sign. This will leads to the staring face or astronoiser face, classically seen in PSP patient. And one more sign is dirty tie sign. Due to the down gaze palsy, most oftenly whenever patient having the food, food will be soiled on the cloths due to the down gaze palsies. This is called dirty tie sign. And the PESA sign, as I told earlier, can be seen in multiple system atrophy. Faces appearance in the progressive nuclear and supranuclear palsy. This is very important. Sometimes you may get as a exam cases, idiopathic Parkinson's disease and Parkinson progressive supranuclear palsy. So these are the facial signs that are described. As I told earlier, omega sign is forehead overcontraction that is leading to the surprise look or astronomer sign. Okay, procerus sign, due to the contraction, over contraction of the procerus and corrugator supercilii, that will leads to the increased vertical wrinkles on the glabellar region. Dirty tie sign, due to the soiling secondary to the down gaze palsies. Round the house sign is whenever you tell the patient to do the vertical gaze movement, patient will not directly do the vertical gaze. Sometimes lateral trajectory movement followed by vertical gaze. That is called round the house sign. This is also seen in PSP. Rocket sign is nothing but lack of postural instability. Whenever you tell the patient to get up from the sitting position from the chair, patient again suddenly fall backwards due to the lack of postural stability. Applause sign is nothing but frontal disinhibition sign. Whenever you ask the patient to just see and follow the examiner, like whenever you clap 3 times, you need to tell the patient to copy same as you did. So patient will not stop doing this activity continuously. Patient will do clapping due to the lack of inhibition. So this is seen in classically seen in any frontal lobe lesions. Because frontal lobe will be affected in progressive supranuclear paralysis, it can be seen in PSP also. This is called applause sign. So brief MMSA score and frontal assessment battery score should be done whenever you are taking degenerative diseases like dementia or movement disorders, because frontal dementia may be seen in PSP, executive dysfunction may be seen in PSP and Lewy body dementia. Apraxias, that is idiometric apraxias, can be seen in corticobasal degeneration, and frontal release sign can be seen in PSP, Lewy body dementia, and vascular Parkinsonism. So whenever you are taking the long case of movement disorder, just you do MMSE scoring and frontal assessment battery scale, FAB scale. Okay. So speech scanning dysarthria again will be seen in MSA, particularly MSAC, multiple system atrophy cerebellar type, and low pitched hypoponic monotonous speech will be seen in Parkinson's disease. Both hypo or hyperkinetic speech, that is mixed dysarthria, can be seen in Wilson's disease. And in a patient with multiple system atrophy, patient will have respiratory stridor whenever talking. So we can mention in the speech that patient is having respiratory stridor along with the scanning dysarthria. Let's come to the cranial examination. First, cranial anosmia. You should examine any degenerative diseases. It may be movement disorder or it may be dementia case. So you need to check olfaction, because IPD, that is olfactory dysfunction, most commonly or earlier you can see in the idiopathic Parkinson's disease, and other diseases like Lewy body also you can see, Lewy body dementia also you can see. And second cranial you need to see for the fundus to rule out retinitis pigmentosa. Retinitis pigmentosa most commonly seen in neuroperitonitis like pantothenol kinase associated neurodegenerative disorders. That is iron accumulation diseases. Most commonly seen in iron accumulation spectrum diseases. So you need to see for fundus, look for the retinitis pigmentosa. And impaired convergence will be seen in multiple system atrophy. Vertical gaze palsies will be seen in progressive supranuclear palsy. Oculomotor apraxia, again PSP. Square wave jerk, these are the brief jerky movements in the horizontal position whenever patient focused on the particular objects. Okay, these are the spontaneous jerky movements most commonly seen in progressive supranuclear palsy. I have videos of these. I think I will show I will show after the class. Next is pseudobulbar palsy. It can be seen in PSP and vascular Parkinson's. So glabellar tap, as all of you know, this is also frontal release sign. This is also known as Meyerson's sign. You need to stand beyond the patient on either side, and you need to tap the glabellar area briskly with the finger. Each tap will be given at the interval of 1 to 2 seconds. And care should be taken to avoid hand or forearm directly coming in front of the eyes. Because of reflex mechanism, you may get false positive reports. So initially in a normal object, these reflex will get habituated after tapping 2 or 3 times. So even after tapping 3 times, although patient having persistent glabellar reflex, you need to think of Parkinsonism or atypical Parkinson spectrum of disease. Okay, this is also known as Meyerson's sign. This is the same diagram, that is olfactory dysfunction, most commonly we seen in idiopathic Parkinson's disease, Alzheimer's, Lewy body dementias. Okay, these 3 diseases you remember. Okay, these are very remember. You must remember idiopathic Parkinson's disease. Okay, this is the earliest manifestation. Sometimes patient will not have any other symptom. Anosmia and constipation may be the earliest presentation of idiopathic Parkinson's disease. So let us come to the ophthalmologic examination. You should know what all the pursuits are, what all the saccades. Pursuits are nothing but slow tracing movement. So whenever you trace the object very slowly, that time eyeball will move very slowly. These are all called pursuit movements. Saccades are nothing but these are the fast movements to focus the object. Okay. These are affected in various neurological diseases. Okay, you need to know what are the pursuits, what are the saccades. Saccades are nothing but fast eyeball movements. Pursuits are nothing but slow eyeball movements. Just you remember that. Okay, these are affected in various neurodegenerative conditions like Huntington disease or cerebral degenerative conditions. Again, as I told earlier, pigmented retinopathy seen in the neurodegenerative diseases of the brain with iron accumulation. That is, iron accumulation diseases like NBI spectrum diseases will affect the retina, leads to the retinitis pigmentosa. And you need to see per the conjunctiva, nail beds, on nose or ear lobules to look for the telangiectasias, because ataxia telangiectasias will have these kind of tarsius telangiectasias vessels, because it will causes various neurological symptoms like apraxia, oculomotor apraxias, cerebral ataxia, chorea, other various movement disorders. So you need to see for conjunctival telangiectasias, telangiectatic vessels. So next, very important cave ring, just brief theory about the cave ring. This is nothing but gold brownish ring at the edge of the cornea due to the accumulation of the copper in the descent membrane of the cornea. In a neurological patient, neurological manifestation, most commonly we see cave ring. 95% of the patient will be having the cave ring in the patient with neurological symptoms and signs. And other in hepatic cases, only 65% of the patients will have KF ring. In 5% of the patient, you may not get KF ring. Okay, so in 100% of the cases, you will not get. So 95% in the neurological cases and 65% in the hepatic cases. And you need to know what are the differential diagnosis for the KF ring. KF ring not always means Wilson's. Okay, in biliary cholangitis, cholestasis, galactosialidosis, and cryptogenic cirrhosis also we can see KF ring. And sometimes in chronic liver disease, local eye disease also, you may see false negative KF ring. Even though patient is having Wilson's disease, due to the chronic liver disease and local eye conditions also, you might not able to see the KF ring. So these are all the false positive and false negative causes of the KF ring. Okay, just you remember the DDs. So as I told earlier, ophthalmologic findings are very important. When we're seeing the patient a movement disorder, depending on the history and examination, you classify whether patient is having hypokinetic or hyperkinetic movement disorder. Say for example, patient is having hypokinetic movement disorders, and along with that, vertical gaze palsy is there. Okay, the probable differential diagnosis would be PSP, corticobasal degeneration, and Niemann-Pick syndromes. Okay, along with if a patient is having square wave jerk, you can make out the diagnosis of progressive supranuclear palsies. If a patient not having any vertical gaze palsy, only having macro square wave jerk, and square wave jerks and macro square wave jerks are only amplitude differences. The amplitude would be more in macro square wave jerks and very less in other square wave jerks. Okay, just I will show the video after ending the class. Okay, just you see whether the patient is having macro square wave jerks or any breaking up the smooth movements of the eyeball, that is breaking up the pursuit. That time you can label it as that time you can make the diagnosis of multiple system atrophy, because multiple system atrophy patient will have macro square wave jerks and breakdown of the smooth pursuits. Okay, because all these will help you to diagnose whether patient is having idiopathic Parkinson, that is the typical Parkinson's disease, or atypical Parkinsonism, because typical Parkinson's disease will not have any interruption of the saccades, pursuits, gaze palsies. If a patient is having these kind of abnormal ophthalmological findings in a setting of hypokinetic movement disorders, you need to always differentiate from the typical and atypical Parkinsonism, because typical Parkinson's disease carries very good prognosis. Treatment would be much beneficial with the dopamine, and chronic long-standing history will be there, and the patient will have various drug options and deep brain stimulation, and various technologies will be there to treat the idiopathic Parkinson's disease. So by seeing the gaze palsy, square wave jerks, you can make out whether patient is having typical Parkinson's or atypical Parkinson's. So always you see horizontal gaze, vertical gaze, pursuits, and saccades. Okay, in a ophthalmological findings. Next, in a hyperkinetic movement setting, if a patient is having myoclonus along with the opsoclonus, opsoclonus is nothing but chaotic eyeball movements both in the horizontal and the vertical direction. So you can have the possible differential diagnosis of paranoid-plastic syndrome, as all of you know, most commonly in a neuroblastoma patient in a pediatric age group and small cell carcinoma of the lung patient will have opsoclonus myoclonus syndrome. In a Huntington's disease, patient will have delayed initiation of the saccades. So if a patient is having chorea and saccades are very delayed in onset, you can again label it as Huntington disease. If a patient is having ataxia along with oculomotor apraxia, you can label it as, you can have the differential diagnosis of ataxia telangiectasia or ataxia with oculomotor apraxia syndrome. Okay, if a patient is on slow saccades, again it will give the clue for spinocerebellar ataxia type 2. And if patient is having macrosclerosis, so again multiple DDs are there. Just you remember, slow saccades causes, oculomotor apraxia causes, delayed initiation of the saccades causes, and opsoclonus causes. Okay, this is a brief flowchart. We'll see the videos. After seeing the videos, we can make the conclusion. What are the movements? That is, what are the square wave jerks, macro square wave jerks? What are the opsoclonus? What is the apraxia? Or what is oculomotor apraxia? So after seeing videos, you can make it out. Okay, just you remember this table and apply whenever you are doing the examination of dementia or movement disorder patient. Okay. Motor examination, it is very important. You need to see per the rigidity whether patient is having only having the involvement of axial muscular axillary skeleton or appendicular skeleton. That is axial rigidity or appendicular rigidity, whether the rigidity confined to proximal joints or distal joints, because most of the typical Parkinson's patient will have appendicular rigidity that is involving the distal extremities, and atypical Parkinsonism like progressive supranuclear palsy will have axial or proximal joint rigidity. So by doing the proper rigidity, by doing the motor examination in the particular aspect of rigidity, you can make it out whether patient is having typical Parkinson's or atypical Parkinson's. And you need to see for whether patient is having symmetrical rigidity or asymmetrical rigidity. Asymmetrical rigidity, again, you can see in idiopathic Parkinson's disease, that is typical Parkinson's disease. And symmetrical will be seen in your progressive supranuclear palsy. Okay. And you should able to mention the bradykinesia. So various methods are there. I will tell you in the bradykinesia testing part. Okay. And reflexes in setting up multiple system atrophy, spinocerebellar ataxia, Wilson's disease, juvenile Parkinsonism, patient will have exaggerated reflexes. That is, brisk reflexes can be seen. So by doing reflex examination also, you can narrow down the various degenerative conditions. And you can see various dystonias, that is anterocolis, retrocolis. Colis is neck, antero means anterior, that is anterior flexion of the neck, that is called anterocolis. Retro is posterior, that is neck is bending posteriorly. Anterocolis and retrocolis can be seen in PSP, oromandibular dystonia, classical of Wilson's disease, cutaneous stimulus sensitive myoclonus can be seen in cortical type of myoclonus, and small shuffling gaits will be seen in idiopathic Parkinson's disease. Small step with ataxic gait, again in multiple system atrophy. In unsteady gait, recurrent fall, erect posture with decreased arm swing, bilaterally symmetrical, that is called gunslinger's gait, is seen in PSP. Frontal gait disorders, most commonly in a setting of frontal lobe tumor, hydrocephalus, normal pressure hydrocephalus, multi-infarct state, vascular Parkinsonism, you can see frontal gait disorders. Typically, patient will have hesitation in the starting of the gait. Then patient will walk slowly, small shuffling steps. Okay. And rocket sign, as I told, due to the postural instability, patient will fall backwards whenever try to get up from the chair. That is seen in PSP. So you can see in PSP. Okay. So extrapyramidal system is very important. So most commonly we neglect this part. So whenever you are taking case of movement disorder, you need to examine for extrapyramidal system. So extrapyramidal system mainly examination mainly done by seeing the tremors, rigidity, akinesia, and postural instability. Just you remember the acronym, that is TRAP, TRAP. So tremor, rigidity, akinesia, postural instability, to be checked in all Parkinsonism or hyperkinetic movement disorders, and even in dementia patients also. Let us come by one. First, rigidity. So rigidity can be checked by holding the hand. Just you keep one hand on the wrist and other hand in the palm of the patient. Just you rotate the hand. Just you do pronation supination movement, or just you rotate the hand in the wrist. So it will give the giveaway sensation. If a patient is having tremors along with the rigidity, will give the sensation of cogwheel rigidity. Okay, so it can be demonstrated in this way. And other way can be, you can do the movements in the opposite limb. Just you check the movement in the examining hand. In this picture, doctor is examining the left hand rigidity. Meanwhile, you can tell the patient to do the right hand movement. So doing the mirror movement, sometimes rigidity will increases. This is called promet sign. If a patient with very slight or very less rigidity, you can make this promet sign. So you can find out subtle rigidity findings also. And other one is Wartenberg sign. If you want to check the rigidity in the proximal joints or in the axial musculature, just you tell the patient to stand, go behind, put the hands on the both the shoulder, just you do the truncal movements. So if a patient have severe resistance, you can label it as axial rigidity. Axial rigidity commonly seen in progressive supranuclear palsy. So as I told earlier, axial more than appendicular, atypical Parkinson; appendicular more than axial, idiopathic Parkinson's disease. Okay. Then come to how to check the slowness. So it can be checked in the upper limbs and lower limb also. Just you tell the patient to just tap the fingers, that is thumb and index finger, and you need to see for gradual slowing of the movement along with the decreased velocity. Gradual slowing will also be there, and amplitude will also be decreased. So that is called bradykinesia. So you need to tell the patient to do for at least 8 to 10 movements. Then you see for the gradual slowing and gradual decrease in the amplitude of the movements. So you can check, it can be checked in lower limb also. You can tell the patient to tap the foot on the bed. So gradual decrease in the amplitude and decrease in the sound. Also you can make out bradykinesia. Or you can tell the patient to write a figure number 8 with the foot fingers. So that also demonstrate the slowness of the activities. And even seeing the gait also, you can make it patient is having bradykinesia. So by truncal bradykinesia can be demonstrated by telling the patient to get up from the chair or the getting out from the bed. So seeing the movement only, you can make out patient is having truncal bradykinesia also. Okay. So measure is, you need to see the gradual decrement of amplitude whenever doing the finger tapping or foot tapping. This is a very important sign, because this is included in the diagnostic criteria. This major criteria of Parkinson's disease. Any Parkinsonism patient should have bradykinesia. Next come to tremors. So tremors can be resting tremors or postural tremor or kinetic tremors. Resting tremor can be demonstrated by keeping the hands in a resting position on the thighs, and you need to check for the Pilroning tremors or the finger tremors in the resting position. If a patient is not having any resting tremor, even though you are suspected resting tremor, then you need to give the task to the patient, because any task or anxiety will worsen the tremors. Just you tell the patient to count the numbers reverse back from the 100, it's like 100, 99, 98. You need to tell the patient to count back the numbers. That time the rest tremors will start occurring in the hands. Okay, so just to keep the hands on the thighs and tell the patient to count back the numbers, then you observe the hand tremors. In a case of subtle tremors, or if you're not able to get the tremors in the resting position, even though you are suspecting Parkinson's disease. Second one is postural tremors. That is, you tell the patient to just outstretch the hands and you see for the tremors, or you can put the paper on the hands, or also you can make out in case of fine tremors. And third picture is the wing beating tremors. You tell the patient to slightly abduct the shoulder and flex the elbow. Then if a patient is having any proximal joint tremor, that time you can see wing beating tremors, classically seen in Wilson. And last one, if a patient is having very subtle postural tremor, if you want to demonstrate the tremor, you need to tell the patient to keep both index finger near the nose, and you should not tell the patient to touch the nose. So whenever approximating the object, near object, that time also patient will start having the postural tremor. This is in case only if you are suspecting subtle postural tremors. Okay, so you need to check all these kind of tremors whenever you get the movement disorder patient or Parkinson's disease patient. So, okay, neck tremors can be seen in essential tremors, cerebellar or dystonic tremors, wing beating, Wilson's tremor, Wilson's disease, and jerky postural tremors can be seen in multiple system atrophy, and tremor is absent in progressive supranuclear palsy. Okay. And last one is pull test. So this will help you to diagnose the postural instability in a Parkinsonism patient. You need to explain the patient regarding the test, and you should take the wall support also. Ideally, normal patient with preserved postural stability will take 1 or 2 steps to uh, prevent it from the fall. If a patient is having postural instability, will take more than 3 steps to recover the balance, or sometimes patient may fall back. So if a patient take 3 or more than 3 steps to recover the balance or fall back whenever doing the full test, you can label it as full test is positive. This is seen in all Parkinson's syndromes. Okay, partial instability is very important because whenever you get the movement disorder, you need to check partial instability. Okay, this is a classical feature of Parkinsonism. So full test you should always do in the extrapyramidal examination system. Okay, next slide. The freezing, as I told earlier, patient will have hesitation, and sometimes patient will stop the movement whenever go through the crowded places or narrow places, whenever turning around the places, or whenever reaching the destination places. This is very classical of Parkinson's disease. Okay, sudden transient uh, gait inhibition can be seen in Parkinson's disease. So freezing can be uh, seen whenever you are doing the gait examination. Just you see whenever patient is having difficulty while starting the movement, turning, whenever going through the narrow places, whether patient is freezing. Okay. Next and last one is cerebellar examination. So you do all the coordination movements in the upper limb and lower limb, see for the scanning speeds and gait difficulties, because some of these disorders like multiple system atrophy, Wilson's, and spinocerebellar ataxia will have cerebellar involvement. So cerebellar examination is also mandatory. Next and last one is systemic examination. Don't forget to look for detailed cardiac examination, arrhythmias, murmurs, hepatosplenomegaly, renal involvement, because movement disorders will affect multiple system, chorea, dystonia, secondary dystonia. So Parkinson's will also have other secondary involvement of these systems. So you can doing the detailed examination will help you to differentiate from the various movement disorders. Wilson's disease do affect liver, rheumatic chorea affect cardiac system, collagen vascular system will affect the spleen and kidney. So meanwhile, we'll have movement disorder. So in any movement disorder, systemic examination is mandatory, because most of these disorders will have definitive treatment. Okay, don't forget to do systemic examination. Okay, thank you. If you have any doubt, kindly ask me.
Sir, we'll go with the video session, sir.
Okay, better we'll go with the videos.
Yes, sir.
This is the applause sign. Patient used to do continuous clapping movements even though after instruction by the examiner. This is the frontal disinhibition sign. I think video is not clear. This is the arm elevation sign, that is alien limb phenomena seen in the corticobasal degeneration. Patient not having any control over the left upper limb. It is moving involuntarily.
साल से दुकान पे साल से दुकान पे
Patient is having difficulty in understanding the speech and he is not able to speak. He is having difficulty in the finding the
वहाँ
words
पे क्या
also.
देख रेख
Case
करते
of
हैं दुकान पे?
corticobasal
अगर फिर खालीगा फोन नंबर निकाल लिया
फोन नंबर निकाल लिया और
ग्राहक कर रहा हूँ ग्राहक कर रहा है अगर फिर ये है फोन नंबर
अच्छा 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 कितना टाइम हो गया करते हुए? कितने साल हो गए?
50 साल
50 साल। अच्छा और घर पे कौन कौन रहते हैं? अपने घर बारे में बताओ, परिवार के बारे में।
होता होता होती बहुत
You take next one, PSP, CBD cards. PSP with suitable work.
कैसे पता आपको हंस रहे हैं?
वैसे हंसे खाते हैं, रोते नहीं।
रोते कैसे हैं?
रोते तो नहीं देखते कभी।
आँख में तो पानी आ रहा
इनकी आंख में तो आंख के हंसने में भी पानी आ
है
जाता
ज्यादा। क्या हो गया बाबा जी? क्या हो गया? हाँ?
क्या दिक्कत है बताइए। हाँ जी, कोई दिक्कत नहीं है। अपना नाम बताइए, नाम बताइए। बोल नहीं पाते हैं पूरा?
बोल नहीं पाते, बैठना नहीं पाते।
ठीक, तो इनकी कॉल में तो काफी मैकेनिज्म कंट्रीब्यूट।
These are the These are the square wave jerks with large amplitude. This is called macro square wave jerks. Okay. Horizontal gauge evoked. These are all the macro square wave jerks. This video is also not clear. Okay, you can see in the Google. Okay, next. क्या दिक्कत है?
तो मैं ये भी उठती हूँ। उठा तो बहुत सॉफ्ट नहीं कह पाती।
कब से हो रहा है? Patient is having scanning speech. This is a case of multiple system atrophy type C.
दवाई तो खाऊं
Typically had autonomic dysfunction, gait ataxia.
नशे तो जाऊं पर नहीं क्या कह दी कई दिक्कत है या
दिक्कत है।
हाँ जी
समझते बात हम क्या बात कर रहे हैं?
हाँ जी
लेकिन बात करने में तुतलापन होता है।
हाँ
ठीक है, पास में।
और
Normally, whenever we are seeing the object, usually we turn the eyeball and we see. In a case of apraxia, patient will turn head completely to see the objects. That is called oculomotor apraxia. You see, completely he is turning the head to see the objects. Normally, we used to turn the eyeballs only whenever you want to see the objects or whenever you want to see the surrounding. Just to see, this is the opsoclonus myoclonus. Patient is having vertical and horizontal. These are the opsoclonus movement. Chaotic movement in horizontal and vertical direction. You see the face, tearing look, and over contraction of the facial muscles and rocket sign. He stand up and again fallen back due to the posture instability. This is called rocket.
Smooth pursuit is a slow eye movement that depends upon foveal, vision, and cerebellar function. Position the patient's head so that it is central and upright and ask them to focus on the tip of a pointer or your finger. Move the target right to left no more than 30 degrees from the mid position of gaze. Increase the speed of the horizontal movement to no more than 0.3 Hz. Repeat this procedure in the vertical plane, holding one of the patient's eyes open if necessary to observe smooth pursuit on down gaze. Evaluate whether there is broken smooth eye movements, that is, jerky movements from right to left, or precisely smooth eye movements as should be normally observed. It is also
Circuits are fast eyeball movements to locate the objects. Pursuits are very slow movements to trace the movement, trace the object. You see, you show the pursuits also.
Smooth pursuit is a slow eye movement that depends upon foveal, vision, and cerebellar function. Position the patient's head so that it is central and upright and ask them to focus on the tip of a pointer, horizontal, or both. Age and fatigue. A unilateral abnormality is on cover testing.
I think video is missing. Okay.
Eye movements that can be generated on command as shown in the video or involuntarily as in the fast phase of nystagmus. They are assessed in both horizontal and vertical planes. Ask the patient to hold their head in a central, upright position, Keep the head still and move the eyes as quickly as possible to fix their gaze on an object, for example, the tip of a pointer and your finger. Hold the two objects approximately 20 to 30 degrees apart and command the patient which to look at. Vary the time intervals to avoid habituation. You should observe an immediate
ಇದೆಲ್ಲ second speed.
movement with no
Previous
delay
one was pursuit.
on the fixation of the target.
Square wave jerks are not nystagmus. They are saccadic oscillations. What you can see are horizontal, fast saccades that take the patient's eyes off fixation and then return the patient's eyes to fixation. They alternate between rightward and leftward direction. They can be easily mistaken for horizontal nystagmus, but they're not. There's no slow phase, only fast phases.
Sir, that's all. Sir.
Over.
Yes, sir.
Any doubts in this session?
No, sir.
Okay.
Thank you. Sir. Thank you so much.